Hello, everybody. We are going to begin our webinar in just a minute or two as we wait for participants to arrive.
Gina, we need some like elevator music or something like that.
You can sing.
No, I really can't.
Wait, I see participants coming in now.
Nice.
Another 30 seconds or so.
I love the folks that show up on time.
Okay, I think we're ready to kick off. We've got a bunch of folks already online. Welcome, everybody, and thank you for joining UnisLink and Nsight for our webinar on how to unlock revenue streams and improve patient outcomes with chronic care programs. We are excited to have you with us today. Before we begin, just a couple of housekeeping items. Number one, we welcome all of your questions. Please feel free to type them in the Q&A chat throughout the webinar. If we run out of time and we don't get to your questions, we will follow up with you directly with answers after the webinar. We will also be sending out a link to the webinar replay so you can watch it again if you missed anything, and feel free to also share that with your colleagues. For now, I will turn it over to James Muir, UnisLink's SVP of Sales, for the remainder of the webinar. Thanks, James.
Thank you, Gina. As you can tell, I'm coming to you from a hotel room in Boston, Massachusetts. So I'll be working from the office when I get back. But there's been a ton of interest in our client base in chronic care management and remote patient monitoring. And they're excited about delivering better care. And they've heard that they can even get paid for these things at the same time. So I thought, who can I bring to our clients that knows this topic inside and out and can educate everybody about CCM and RPM. And so we already had a partner that does that for many of our clients. That is Nsight. And so I am excited to introduce to you all Mike Shulo, who's the CEO of Nsight, whose company does this professionally all over the United States. So, Mike, thank you so much for taking the time out to come and educate us. Before we get into it, do you want to just give folks, a brief overview of Nsight so the folks that are attending know what you do?
Yeah, that's great. And first of all, thank you for inviting me today. Very grateful to be here.
We're happy to have you.
And excited to educate everybody about what these programs can do, and how exciting it is that we're able to help so many people across the country. So, Nsight is a remote care company encompassing everything from remote patient monitoring to chronic care management, to remote therapeutic monitoring, principal care management. You pretty much name it. If it involves us remotely taking care of the patient from home, we do it. And we have a turnkey service that basically does 99% of the work for clinics, so they don't have to hire anybody, and we can take care of their patients from home. The whole goal is to not only improve patient outcomes and really prepare providers for the transition to value-based care, but it's also to really help providers generate a new stream of income when, as they all know, reimbursements are getting lower and lower every year. So finding new ways to generate income for your practice becomes extremely important to survive in today's environment. So these programs help financially. The patients love them because it's really improving access to care and improving patient outcomes. And again, we're doing this for hundreds of practices across the United States, everyone from primary care to cardiology to nephrology to endocrinology, your single MD down the street, all the way to some of the largest health systems in the United States. So it's a very exciting time. We're just at the beginning of the remote patient monitoring, chronic care management kind of future that lies ahead, and we're one of the pioneers of the industry. So it's very exciting to be here.
Yeah, in fact, it kind of seems that that's the direction that all the value-based care is going in this direction. And so, Yeah, probably most of the groups, they may have heard about it, but yeah, give us a sense of how RPM and CCM help practices prepare for this transition that everybody's, this journey we're on towards value-based care.
Yeah, I mean, well, I think, think about 10 years from now and look back, and people are going to think it was absolutely crazy that we only saw patients in person once a year or twice a year, right? Or even 3 times a year for some of these patients that are suffering more, from more issues and more chronic conditions. And the ability with technology coming out to be able to more proactively monitor patients makes all the sense in the world, if you think about it, because so much of healthcare, our healthcare system has been designed around what do I do once the patient is sick, right? That's when they're coming to the doctor many times, and value-based care is really not no longer focused on how can I see 30 to 35 patients a day as a provider, that transactional volume, but how can I actually manage the largest patient census possible for the least amount of effort and resources put out in order to keep them healthy. And that's a very difficult mindset to ask a provider to change, because you're basically asking them to change their entire way that
Right.
they make their money and how they've built their business over decades and their livelihood. So you have to make a transition slowly. And so some of the things that you can do and kind of prepare yourself are programs like this, where you're able to start closing gaps in care in between visits. And that's something that a remote care company is able to do. We can identify, the assessments that they haven't gotten completed, the appointments that they haven't been to, maybe the annual wellness visit that they shouldn't have got, or that they should have had, but the resources weren't in the staff in the clinic to be able to do it. And so a lot of these things can start to be handled on behalf of the providers. So the provider can look at these types of services as really an extension, additional resources to be able to start to check off on closing gaps in care, checking off on these HEDIS measures, helping to gain additional MIPS credits, and just start moving in that direction. Interestingly enough, one of the ways we're helping providers and health systems prepare for value-based care is we're collecting millions of data points on these patients in between visits, all their biometrics, so blood pressure readings, blood sugar readings, weight, etc. We're collecting their hospitalizations. We're looking at all of their medications, all the different providers that they see. We're really getting a very good holistic view of what's going on with the patient, which in time is really going to allow us to understand who are the patients that we drive down the cost of care for the most. And the reason that's important for providers that are moving towards that value-based care mindset in the future is really going to be, you have a limited amount of resources to keep a large group of patients healthy. How can I expend, again, the least amount of resources on the right patients at the right time to keep them healthy? Well, the only way you're going to be able to do that is by having that remote care connection to your patients in between those visits to know truly and have the visibility to be able to make those decisions. So I believe that anybody that wants to move towards value-based care, a remote care program is absolutely a necessity. We're seeing a big shift in the market that with the rate of growth of our company and our competitors, I think it's holding true. That's kind of the sentiment. So I hope that explains, where I believe these are going to be super important for value-based care as that transition comes.
It does. And you said a lot there that I want to key off of, but maybe to give us a little frame of reference, let's do a quick poll with our audience and kind of get a sense of, at least with the attendees, kind of where they're at right now with their understanding or their engagement with either RCM or CCM. I think she means RPM on that survey there. So remote patient monitoring or chronic care management. So I think it's just one option here for you to pick, kind of where you're at in your spectrum. Just go ahead and pick that. And then I think we'll get to see some results here in just a second, and we can get a sense of, is everybody on this call already implemented one, or are people just thinking about it? What do you typically see, Mike, when you're out there with clients? Is this, are we at the beginning part of the bell curve here? Or are we well into the adoption phase? Where do you think the market is with this?
Definitely at the beginning of the bell curve. If you look at claims data, only about 4% of patients that are eligible for these services are actually enrolled in them. There is a study that shows that 90% of patients over the age of 60 suffer from one chronic condition, and 80% of them suffer from two. So anybody that has two chronic conditions or more are eligible for CCM, and people that have one chronic condition that would necessitate a medical device, being remotely monitored from home, hypertension being the most popular, is eligible for RPM. So we're very much at the beginning. The providers we're working with are innovative. They are thinking ahead. And maybe it would be good for me to give a little context, because I know there's a lot of programs we offer, but the two most popular are RPM and CCM. Mm-hmm. So maybe would it be helpful if I gave a little bit of background and context on kind of those two programs?
Yeah, let's see if we've got some results we can share. Gina, do we have something we can share with the group?
I do. Yeah. So it looks like the most popular answer was no budget or no staff. There are a couple people that are in the early stages of implementing a program, but most folks said no budget or staff.
Okay, so that's interesting because Mike, as you were talking about, getting the right people working with the right patient at the right time to make all of this work, I thought, oh my gosh, this sounds like it could be challenging to implement. So, give us an idea of how tricky is this? Is this a heavy lift? Is this an easy lift? If you do it the right way, is it simpler? So, coach us a little bit on that.
Yeah, definitely. Maybe I can actually pull up a different slide here that goes over how easy this is to implement. So, we are a fully turnkey service. So there are companies out there that can basically do everything for you, where you don't need a budget, you don't need staff, because the way at least our model works is everything's paid for performance. So we will actually pay for all the devices and deploy them to all the patients. We will enroll them in the program and educate them. We will conduct the monthly care coordination calls, with the patients, with our nursing staff that we employ. We will make all of the codes billable, so that all that the provider's office has to do, or if they have a billing company like yourself, is make sure the claims are billed, right? And make sure that the documentation is being reviewed when the provider meets with the patient in person, which we're pushing all those documents directly into the patient's chart within their EMR each month. So it makes it really easy to do this review each month. And so the lift on their end is very light, because there's no additional hires needed. There's no additional budget. And the reason why, again, is because it's paid for performance. Only once they get paid from insurance is our fee due thereafter. And the interesting thing is that typically this is generating about $150,000 a year in profit for the companies that we work with, per provider that they have on staff. So not only do you not need a budget or staff, it's 100% return on investment, because it's pure profit, because we're just sharing in the reimbursement that they're collecting from the insurance companies for these services to be provided. So with regard to getting up and running, I'm oversimplifying, but really we do an onboarding call to really gain all their clinic information. We gain access to their EMR so we can identify patients that are eligible and run insurance eligibility. We do a kickoff call with their staff to educate them about how the calls are going to go and how questions coming in, how to answer those if patients come in with questions. We then begin enrolling those patients ourselves. We take care of all that heavy lifting. And then we do 3 separate trainings, and training them on our software program, which again is all integrated with their EMR. So a lot of people aren't even using it. They really just, we show them how to use it if they need to access it. We explain to them how the financing portion works, which I just explained. You get paid first. You let us know if anything got denied or anything went to deductible. We'll write it off before you pay us. And then we also introduce them to our clinical team, our chief medical officer, our director of clinical operations, to make sure everyone's very comfortable with, how we're providing care to those patients in between visits. But I hope that gives you a little bit more insight.
It does. So let me ask you another question around that. So their lift is fairly minimal, but not every CCM RPM program is like that. What is going on behind the scenes that your organization is doing that makes it easy for the providers on their side?
That's a great question. Let me give some quick context for RPM CCM, and then I'm going to walk you through exactly how we do it differently, because it's a great question. Because we've talked to providers in the past where they've said, oh God, we tried this and it was a disaster because we had to buy all these devices and then we had to hand them out. And then, there was troubleshooting, and then the patients had to connect to Bluetooth and they didn't know how to use technology well. And we've heard it all, right? And so we've solved for a lot of these issues. But before I do that, let me give some quick context on RPM. So just anybody that doesn't know, RPM stands for remote patient monitoring. And what that is we are identifying patients that necessitate being monitored from home. This could be something as simple as they've got high blood pressure, they've got congestive heart failure, they may have COPD, diabetes, you pretty much name it. But we've got everything from a blood pressure monitor to a glucometer, weight scale, pulse oximeter, and more, even pill dispensers to track and identify biometrics from these patients in between their visits with the provider. Vitals can tell us a lot. So the vitals coming in, what happens is if we see something abnormal come in real time, one of our nurses picks up the phone, contacts your patient, and does a clinical assessment. And if it turns out that patient is in fact symptomatic, if it's life-threatening, we'll get 911 involved right then and there. But most times it's not life-threatening. It's just a simple care plan that needs to be changed, right? Or a therapeutic that needs to be adjusted. And so we'll actually schedule an in-person preventative visit with their provider to be able to make those changes to their care plan. So that's really what RPM is. It's the idea of looking at metrics over a long period of time in between visits to be able to make better clinical decisions with your patients when you do see them in person. And then what CCM is chronic care management. Look at that as a concierge program for your patients, meaning that they would be assigned a personal care coordinator. This would be an LVN or RN. And this care coordinator is assigned to that patient to first and foremost build a great relationship. And throughout that relationship, the first thing we do is either an annual wellness visit if you're not doing them, or an intake assessment, which is very similar to an annual wellness visit, which basically means we're going to figure out what's every single provider they're seeing, what's every single medication they're on, what's their diet look like right now. We do a social determinants of health screening to see, hey, do you have access to food? Do you have access to transportation to and from your doctor's appointments? We see if they need prescription refills. We schedule their doctor's appointments for them. If we identify that transportation is a problem, we'll actually schedule it for them. And we give them a 24/7 line they can call or text anytime to reach a member of our clinical team to assist them with anything they need. So look at RPM as like a reactive service where we're identifying the metrics after they come in to make care plan adjustments, where CCM is about preventative care, educating patients and making sure that every gap in care is being closed that needs to be closed. Just think of anything we can possibly do to keep that patient healthy long term is what CCM is for. So with that being said, by combining these services, this is how we're able to really move these providers in the right direction for value-based care. And so to your next question, you would ask, well, how do we make it, I guess, easier than the next company, right? So the first thing we do is we identify patients that are eligible for the program. So the typical clinic, gives us access to their EMR, and then we log in and we identify which patients are eligible. We look at their chronic conditions to make sure that they are eligible for which services. We then check insurance eligibility to ensure that their insurance will actually pay for these services. And then from there, we actually will contact the patient. And what we do to be unique is we mimic the caller ID of the clinic itself. The reason that's important is we found that the ability to enroll patients is far higher if it appears as if we're calling directly from the doctor's office itself. So we actually keep all our enrollment agents in-house to ensure we have extremely high quality, but their objective is to educate the patient about the service, explain why their provider wants them specifically to enroll. We explain any cost sharing that's applicable if they have a copay. These are Part B services, so if they don't have secondary, they are applicable to a copay. So we explain what that cost would look like in that instance if they don't have secondary. And all of these are recorded. We want to make sure everything's recorded, everything's documented for compliance purposes as well. But we take care of all of that. Now, as the patients agree to join the program, which, by the way, 9 out of 10 that we get on the phone agree to participate. So
wow.
The patients are a lot more open-minded than you would think to these services. They see this as a value add. This is something, and the way we also explain it to them is, hey, it's not because you're old and sick, right? This is because this is the future of healthcare. This is the way everything is going. And I think with Apple Watches and Fitbits and that kind of proactive monitoring people are used to now, it's not crazy to think that, you know, their doctor's rolling out a program that would allow them to be monitored in between visits. So we've got a very high enrollment rate. And when they agree to participate, we then pay for the device, Nsight does, on behalf of the doctor and on behalf of the patient. There's no cost to them. And we ship it directly to their home. What happens is when they pull that device out of the box, it automatically works. There's no Bluetooth to set up. There's no mobile app to download. We made it super easy. You know, our average aged patient is 75 years old. And not to say that, you know, 75-year-olds aren't tech savvy, because they are. I mean, most people now have a smartphone. Even my 95-year-old grandmother has a smartphone now, which I was shocked to see. But, you know, it's the point that no one likes setting up a Bluetooth device. No. You know, nobody likes having to download a mobile app. So what's great about these is just like your cell phone has a SIM card in it, these devices do as well. So when you pull them out of the box, you use it, and it sends that reading directly up to the cell tower securely and directly into our software, which then pushes directly into the EMR of that provider. So the patient doesn't need to worry about a complex setup. And we're actually tracking this device. So the second it lands at the patient's home, one of our onboarding specialists will call the patient, train them how to use the device, and make sure that we get an accurate reading. From there, now patients are taking readings, and going back to what I explained earlier, if we see an abnormal reading come in, we're proactively contacting them. We are making sure that they you know, have everything that they need. The care coordination calls are set up monthly so that we're bringing them through a really robust clinical pathway that our chief medical officer set up to make sure we're checking off on every quality metric we can. Gaps in care are being closed proactively. And yeah, it's that. So I guess the last thing I'll say here is what makes us different too, is that we generate the billing files. So, you know, providers don't need to worry, and office managers, they don't need to worry that, gosh, this sounds like a lot's going on in the background. You know, what do I need to be worried about? Honestly, not a lot. We take care of all the heavy lifting. For your providers, we push the documentation to the EMR. We'll call you based on their escalation protocol. If something is wrong, we know who to reach out to. And again, we're not calling people at 2 a.m, right? This is preventative stuff. If it is life-threatening, very rarely it is, we'll get 911 involved. But normally it's just, hey, the patient, we recommend an in-person visit. And what happens is at the end of the month, as all these codes are becoming billable for the time that we're spending, we send a report to the provider. And many times if they use a third-party biller, we'll send it directly to the biller so that they can then go and bill all those claims and then get paid for those services. So yeah, again, the idea is it's turnkey.
Yeah, well, obviously that last piece is where UnisLink fits in. But since we're bringing up other platforms, integrations, things like that, tell us a little bit about how does the client or the clinic's EMR fit into this whole scenario?
Good question. So it depends on the EMR itself. Some we have more robust integrations with than others. But for all of them, we can push the evidence of care documents within the patient chart each month as a PDF. So the providers don't have to go anywhere else to see what's been going on with that patient's vitals over the last 30 days, what was discussed on their most recent care coordination call. Also for compliance purposes, all that information is stored in there. That would be like the minimum integration. On more advanced integrations, depending on their EMR, we can go as far as to sending discrete vitals into the patient chart automatically. We can actually send claims through the EMR automatically. You know, we can allow for two-way messaging and actually bi-directional updates being done. But honestly, for a lot of our independent practices that are 10 providers and below, because a lot of the larger ones will be using Epic or Cerner or something like that, or ECW, where that integration is very robust. But if they're like on a Practice Fusion, or they're on a something that's not maybe as enterprise ready, or like a next gen, for example, we have the basics to be able to get the job done, to push the documentation in.
I got you. You got me thinking about compliance. Is there any compliance issues going on when you're running a program, a remote care program?
Definitely. We have a full-time chief compliance officer on staff, because, compliance, anytime you're starting to bill government payers, more revenue, you need to make sure that all your ducks are in a row. So everything we're doing, it has been looked at by our compliance officer. We work with really large health systems as well that have very robust compliance departments that we had to pass the test with in order to even provide the services at that level. And compliance is everything. You have to make sure every single call is recorded. You have to make sure every single item is documented. A lot of the codes that we're billing are time-based codes. So you need to be able to have a good way and software of tracking that time and proving that you actually provided care. Because really, we've seen, we've got hundreds of customers all over the US, and we've seen customers get audited, not due to our services, but, in general, they'll get audited. And part of that will become, hey, we want to look at RPM and CCM. The two things they seem to really be interested in when they look at these services: did the patient provide consent? Right? Did they know they were enrolled in the program? And did you cover the 4 items that were necessary during that call? Do you have proof of it? That's kind of the first thing, and which we always obviously keep on hand, and all of that's documented. The second thing is, okay, well, if you're going to bill us for an hour of time, how do you prove that hour of time? And that's where really thorough documentation comes in. Very good SOAP note templates, clinical notes that are going in are very thorough. Again, every call is recorded. So compliance should be a concern to everybody if you're going to roll out a program like this. So it's really important that you do your due diligence and make sure that the company you're contracting with has really thought it through, and they can actually prove to you that they've got a really robust program in place that will protect them in the case of an audit.
Okay, so just backtracking a step here, it sounds like they can just use the current EMR that they have to do the work that needs to be done on their side. Did I say that correct?
Yeah.
Okay.
Sorry,
so
I overcomplicated.
We're not introducing new systems or anything like that. Okay.
No, not at all. I mean, we have a software of our own, and if they want to, they can log in and see what's going on in more real time. But most customers of ours just operate out of their existing EMR.
Okay, because all you said there is a big deal, right? So is it fair to say that if you weren't taking those functions on, anybody trying to run a CCM program or an RPM program would have to do all of those things on their own? And sometimes that becomes problematic, since they're dealing with devices, and they're dealing with onboarding, and they're dealing with renewals, and they're doing all those things. Is that fair to say?
Definitely. Yeah.
All right.
Yeah.
All right. Very good. Very good. So, and of course, they've all heard that there is revenue possible here, and you alluded to that at the very beginning of this session. So, give us a sense of, what is the upside for a clinic to adopt one of these remote patient monitoring or chronic care management programs, and maybe you could, in addition to saying the revenue side, you could just kind of say, and here's how much work that is, since you guys are taking off much of the load.
Yeah, so it's a fair question, and I think this is usually what gets our foot in the door. I mean, providers are extremely busy, and clinics are extremely busy, and so if it can really increase the financial vitality of a clinic, it makes it a higher priority, as it should be. These services typically will generate about $150,000 a year in net profit after our fees are paid per provider on staff. So if you had, simple math, 10 providers on staff, it could be a $1.5 million lift in profitability.
What's the assumption on the patient panel size for something like that?
Yeah, with that, we typically see all said and done about 100 patients enrolled per provider. Now, there's usually going to be about 150 to 200 patients eligible per provider. And that would be in the primary care setting, cardiology setting. Now, if you get into like a nephrology setting, you can double that number. It just depends on their specialty, because certain specialties just happen to service more elderly patients than others.
Sure.
It also depends on, of course, where your clinic is located. If it's in Naples, Florida versus, downtown, in some metropolitan. But what I will say is that these codes, they started back in 2015 for CCM, 2018 for RPM, and they keep getting higher each and every year. We only saw one cut to a code once, but they raised other codes at the same time. So this is what a breakdown of those codes are, and I'm not going to bore everybody to death today going through each one individually, but just know that there's a reimbursement for the first time the patient uses the device. There's a monthly 30-day payment as long as the patient takes 16 or more readings in a given month for RPM. And then the 99457, 458 codes there on the left-hand side, they're about, third and fourth down. Those get paid based on how much time my staff or our nurses spend with their patients on a monthly basis. So that's not their time, but the more time we spend with the patient monitoring their vitals or speaking with them or doing our care coordination calls or communicating with them, the higher the reimbursement to justify the payroll to do so. With CCM, it's all time dependent. So depending on if you get 20 minutes, 40 minutes, or 60 minutes will necessitate how much money gets reimbursed. We also do behavioral health, which we didn't really focus on today, but there's an element of behavioral health screening that we do, and we help with, diagnosing depression, for example. Helping to identify undiagnosed depression is the better way to put it, because it has there's a study that came out that showed that undiagnosed depression leads to a much higher chance of rehospitalization, which makes sense, right? If I'm depressed, I'm less likely to follow my doctor's advice, right? And take my medications than if I have that diagnosed and treated. So anyway, it just depending on the services being provided will generate reimbursement. And then our fees, are all dependent on once those reimbursements are actually verified to have been paid. So typically what happens is after the month ends, we send an invoice out. Typically it's a net 40. So a billing report comes out saying, here's everything you can bill for the services we did. Basically, you've got 40 days to go bill it, get paid on it, make sure that you were paid on it, at least on the primary payment, and then turn around and pay our bill. And that's where their revenue cycle management partner, like yourselves, will work directly with our finance team and true up that invoice to just make sure that if there were any denials or there were anything that didn't get paid, that those get written off our invoice before they get charged. And all said and done, this is what a typical profitability would look like from a clinic, depending on how many patients they end up getting enrolled.
Yeah, well, I can vouch for that because we have several clients that are using your services. So that's how this meeting came to be. So can you give us an idea of, from a specialty perspective, what specialties tend to be the best match for, chronic care management, remote patient monitoring?
Yeah, most of our customers are primary care providers. We have a lot of nephrology groups, helping patients with CKD. We've got a lot of cardiology practices, endocrinologists, helping diabetic patients. We've even started venturing into neurology and pain medicine because there's a new service we're providing called remote therapeutic monitoring, which is actually monitoring medication adherence, which becomes really important for managing pain meds and as well as neurology medication and things like that. So, but I would say predominantly primary care, cardiology, and nephrology. But again, we're open-minded because, we've even spoken to oncologists that see a good fit for this. And, it just depends on, the doctor is going to have to decide for themselves what necessitates or what has medical necessity and what doesn't. But if they see something that would help them in their practice, we're open-minded to exploring beyond those few specialties.
Is the assumption here that these are all government contracts? These are Medicare? basically, or are there other payers that will pay for these things besides Medicare?
Great question. Yeah. So Medicare, definitely, Medicare Advantage. But funny enough, commercial typically follows suit with Medicare, and we're seeing more and more commercial payers pay for it. So because CCM has been around a bit longer than RPM, we see more commercial payers paying for CCM. And so you'll see an interesting mix when we run eligibility where you'll actually have more patients enrolled in CCM because more payers pay for it than your RPM program. But we do see that there are some commercial payers following suit with RPM, and I think it's just a matter of time. And then also some state Medicaid programs have started to pay for RPM, which has been great. States like Ohio, we started to enroll many patients into RPM, and states like Arizona. So we're actually even seeing state Medicaid programs follow suit because they're seeing that this really does work, that there's efficacy to it. It's reducing the cost of care. But to quickly just go over this pro forma here, just anyone's wondering what this 0% is to 100% is, this is just a pro forma taken, I believe, of a California reimbursement geographic. And what it's showing there is that if patients were enrolled in just RPM and CCM, and none of them had secondary insurance and nobody paid their copay, which is highly unrealistic, the profit per patient after our fees were paid would be $97. So again, that's after our fees are paid, net. If in the off chance everybody has secondary, which is also highly unrealistic, and pays their copays, you would make $168 per patient per month in profit. So what we figure is 50% roughly on average will have a form of secondary or pay their copay. So we'll say, hey, the average profit is $133 per patient per month. And so that's where you can see here when we say the average doctor has 100 patients that are enrolled in the program, all said and done. That's where it's generating that $13,000 a month in profit, $159,000 a year in net profit to the provider. So that's where we get that $150,000 number from.
Yeah, fantastic. In fact, that's a bonus for us today. Thank you for sharing that piece. So here, harder question. Where do people get tripped up if they are, if they're adopting a remote patient monitoring and chronic care management, where is the hiccup or the bear trap or the catch that they bump into?
Yeah, this is usually it's funny you ask that because this is usually when we get asked, like, okay, it seems too good to be true. What's the issue here?
What do I got to watch out for? Yeah, exactly.
Yeah, well, I think that just being frank with everybody, you can't build these programs without there being, I have this saying that you can't make an omelet without a couple broken eggs, right? And you can't introduce a new program to hundreds or thousands of Medicare-age patients and ship a device in the mail to them and ask them to start taking their readings from home and ask them to show up to monthly phone calls and change their behavior and not get some pushback, right? Like some patients are going to be very, very, and the good news is I'd say 90 to 95% of them are going to be very on board for this and they're going to be excited by it and they're going to appreciate the advanced care. But just like the same patients that come in and complain at the clinic, right? You're going to have those that do not want to do this and they're offended by the even question of it and will then therefore complain. And so the hard part about these programs is keeping things in perspective in the beginning. And what I mean by that is if I enroll 100 patients into the program and let's say 100 patients in the program and 5 people came in and complained, that might feel overwhelming for a provider or an office staff that's not used to getting really any complaints. And they go, oh my gosh, what's going on with this program? This doesn't work. I think people are really upset. And it's like, well, hold on, you've got 90 patients or 95 patients that are really happy, right? And it's just so I will say in the first 3 months of these programs, as you're deploying devices, as you're training patients, as some of them decide to bring their devices into the office, as some more questions are coming into the staff temporarily because they have questions about the service, which of course we ask them to redirect to us. But then as some patients complain that they get a copay, right? And even though we warned them and told them that they would, they'll say no one ever told me. So these programs temporarily create complaints for a few months. I mean, I just want to be honest and we'll tell every customer that because you just can't build these without some friction along the way. But the good news is after that 3 months, it just becomes automated, right? It becomes very much just a part of the practice, just like anything else. If you really want to build the program, you have to go through that period. So I'd say that's the first piece. That really is, that's why it's not too good to be true. And I think the other half of it is if people understood how much we had to do over here, from our analytics team to our device expenditure to the insurance we have to carry, the 24 staffing that we have to have, the software that we had to develop, the SIM cards that we have to pay for those devices, the artificial intelligence we use, the enrollment team we use, the onboarding team, the adherence team. It's a really robust, complicated operation to do. And that's why it feels too good to be true, because we've taken so much of the work that it would be very difficult for a practice to do this on their own, because you have to build out such a robust, operationally disciplined company or division to roll something like this out and not lose money while doing it. So those are the 2 points I'll say.
Yeah,
you can't build anything new without there being some friction, and there's a lot behind the scenes that you don't know what's really going on.
Any tips on how to navigate that first 3 months? Just push it all back on you. What would you recommend?
Yeah, it's a good question. I think the best thing is making sure that your staff is really paying attention when we're doing our kickoff call and really studying our FAQ and the proper response to certain questions, because it can be as easy or as hard as you want to make it. We put somebody on site for a lot of our deployments to make sure that it does go smoothly and the staff is trained and they know how to handle these questions. But you really have to make sure that the communication within your staff is good, and maybe even coming up with a temporary incentive to actually help them with that additional workload, because trust me, they'll appreciate it. We try to do things like throw catered lunches throughout that process, try to remind them throughout each day that as we get more patients enrolled, what the good recorded phone calls sound like. So we try to keep things in perspective the best we can, but I really do think that it would be wise of the provider to make sure the communication is great within their team, make sure that maybe there's some sort of temporary financial bonus they can give to help our team with getting this program up, so that people, are willing to put that extra time and effort in than they normally would otherwise be able to. But look, most people don't do that and it still goes fine. But if you're asking me what would I do if I was a doctor, I'd probably be being extra nice to my staff for a couple of weeks as I'm going through those enrollment phone calls.
Yeah, great tips. Great tips. Well, we have a number. So part of our mission at UnisLink is to help improve the practice's revenue, right? So since this is a revenue enhancing strategy, it's in full alignment with our strategy to help improve the revenue of the client. And we have a number of clients that are doing this. That's how you and I ended up getting connected. And so do you have any examples of, it doesn't have to be one of our clients if you don't have one handy, but, examples of some, of the successes that current clients have had with this?
Yeah, so here would be a company out of Northern California that's, they've got their hypertensive patients on blood pressure monitors. We've got some CHF patients on weight scales. And diabetics on glucometers. And really what we saw was that this is a 1MD clinic, okay, just happened to be servicing a large group of more Medicare age patients, a more elderly demographic. And within the first month, we were able to enroll 453 patients into the program. So this is a bit of an abnormal situation where one doctor had a large number of patients that were eligible just because of the demographic they were in,
Sure.
that they serviced. But after their third month, because it does take a little bit of time for the profit to truly be realized, because you've got a lag between primary insurance and secondary insurance and all that. They were never underwater, but it does take time to realize that full profit margin. About 3 months. By the third month, they were profiting $26,000 a month. So after our fees were paid. So it's a substantial, as you can imagine, a lot of doctors, 1MD practices, if they're profiting that in general, that's good. But if they can actually bring this amount of additional profit in, it can be quite the game changer. I've talked to a lot of my doctors that are, in their their later years of running their practice, and they're looking at this as an opportunity to put towards their retirement. So, and then of course, newer practices that are looking for any ancillary services to increase their profitability. I think what more and more we're seeing is that as reimbursements are declining, in order to remain a profitable clinic, you have to get creative. You have to find ancillary services. I'm sure you guys are teaching your clients all the time, whether it's coding, better coding practices,
Right.
or other ancillary services. You have to do these things if you want to survive, given that the reimbursements continue to decline.
Yeah, well, as of this recording right now, unless something changes, everybody is going to take a 2.3% cut from Medicare reimbursement next year in the beginning of 2025. So that is exactly the dynamic that we're trying to fight here by providing extra revenue for clients. So thanks for sharing this. We're kind of coming up on time here. We try to keep it to 45 minutes or so. We can look and see if there are some questions here, but maybe you could, if someone wants to know how they could get engaged with you guys, what's the best way for them to do that?
Yeah, we've created this QR code here where you can easily set an appointment with our team, and we'd be happy to meet with you. Really what we'll do is we'll do a more in-depth review of the program. We'll ask a lot more questions about your practice specifically. And then if you're interested in proceeding, we try to make it really easy. We ask for a BAA to be signed just to protect the patient privacy. Then we begin pulling all the patient information. And usually, depending on the size of the practice and how difficult it is to get access to their EMR, sometimes it can be accomplished on that onboarding call. Other times, IT has to work at it for a month, or we have to get through approval through Epic or a hospital system.
Sure.
But usually we're able to turn around and start making phone calls within 2 to 3 weeks after that. So it can be pretty quick, depending on how fast they want to move. We do have a couple dozen clinics right now that we're implementing. So usually, if anything, the delays on our end, just making sure that we have the proper resources to, onboard them, and do it with good service.
Mike, thank you so much. And I appreciate you doing the interactive format so I could just pimp you down on some questions and get the answers
no problem.
that our folks are looking for. Yeah. And so maybe we'll do another one of these if there's interest. I'm sorry to those who may have fielded questions. We try to keep it to 45 minutes, but we will get to your questions and we'll respond to you offline. Everybody who registered for this webinar will get a recording of the webinar. And then, Mike, if you're okay, we'd love to have you back maybe sometime in Q4. But thank you so much for sharing your wisdom and insight on these programs, because it's kind of new for everybody and everybody's excited about it, but they're really uncertain about what it takes to succeed in it. And this has been a big help.
Great. Thanks again, James. And thank you to the UnisLink team for putting this all together. And I appreciate it.
Okay. Thank you so much.
Thank you. Take care.
Thank you, everybody.